So, the background for the decision that was made last week relative to the shift bid, I think that we really need to put it into context of the emergency that we're continuing to respond to. So we've been in pandemic response since March of this year. And frankly, early in the pandemic, we saw a real decrease in call volume. And we had, at the same time, a spike in isolations and quarantines of our own folks, but the volume on hand was significantly less than we were used to. And so we were able to manage that volume with the staff we had on hand. We were able to meet our response time targets, manage workload, and fortunately, even with that reduction in volume and then subsequent reduction in revenue, we didn't have to make any really more aggressive moves besides idling down overtime and not paying overtime. We know overtime is important to folks, and that some people count on overtime, even though overtime is something that's transient. That was the depth of the cuts we had to make. We didn't have to furlough. We didn't have to lay people off, which was great. And then, the situation changes and we come out of that lockdown phase and into the summer, and we see a little spike in both volume and infection in July. And in July, we had to take some, staffing interventions is what we're calling them, related to making sure that we have appropriate pairings ahead of time, making sure that we have the right amount of overtime open in the places where we need it, beginning to ask more of our administrative staff as it relates to working in the field, as well as their work here supporting all of the projects and operations of the business we have going on. And then we transition here into the fall and winter, where we're in the midst of, what is a surge of coronavirus cases here in our community. And then locally within the organization, we have the highest sustained number of people we've had on isolation and quarantine at one period of time. People come off and people go back on. And so that causes instability in our schedule and instability in forecasting the number of unit hours we're going to produce. And so we had to take a look at all of the options we had. And one thing we could do is retain stability in our schedule by staying where we are. And basically by sitting down and saying, we know what we can produce today. We can predict that well into the future. And so we're going to sit on this schedule until such a time that we think the pandemic will be mitigated or we'll move past this crisis phase. And so it's just another step in our response to the pandemic and how it is affecting our ability to do work. A lot of folks think that and have been told over lengthy time here that a new schedule is a panacea to fixing all the ills of unit hour production. And unfortunately, it's not the case. A new schedule will help align shifts somewhat better with demand over time. But in the end, a new schedule is a prediction and a forecast about where we think volume is going to be in the months ahead. We set a prediction in October for where we think calls are going to be the next October. And with that comes volatility, especially in the first couple of months we release a new schedule. And so we wanted to not have that volatility and stay where we are with something that is not perfect, right? And most schedules are not perfect. When most global schedules are not perfect. We want to stay where we are with something that we knew how it behaved and knew how we could manage it, instead of adding a third variable in or a fourth or a fifth or however many variables we're up to right now about managing unit hour production. That's a long and arcing way of how we got to where we are today. So from way back when we started in March to kind of where we are today.
Awesome, thanks. I don't see any hands or comments yet, so I'll take another one from Yammer. Is there any chance this decision could be reversed or end earlier than expected, or could it even be extended further?
So kind of three parts to that question as I heard it. Can we reverse the decision? So no, we are delaying the January change of shifts. Can it end earlier than expected? So we're going to have a really limited period of time to end this earlier than expected and move people to their bid upon shifts. And so in the end, when we think about moving back to our shifts early, a couple of things have to line up right for us. So vaccines are going to start coming out for our organization now. If we have good uptake with that and internal cases of quarantine and isolation start to decline, if hospital capacity opens up and we're not concerned about increasing turnaround times because we can't offload our patients quicker or at our standard rate, and if we don't see a surge in transport volume because of general increasing illness in the community, we could consider, those are all positive things, we could consider adjusting when we would want the shifts to change. Now, we have to take into mind when we do that, we do have to give people a fair amount of time to rearrange their life for what their next shift would be. And so I think it would be unfair of us to make that decision, you know, the 1st of March and say the 14th of March, we're going to have a shift bid when we would just be waiting until April. So in all honesty, if we're going to do anything early, we will need to make that decision likely by mid or end January to make sure that we give enough advance warning to folks that shifts are changing. And then will we extend it is the third question in that. And I have no intention of extending it past April. And our goal is to not extend it past April. And our plans are not perfect. And there are circumstances that could come about that would make it necessary to do so. So I cannot commit today that we would never do that. But my goal and the goal of the ops team is to have that as solid a date for folks as possible. I don't want to continually push dates out because that, you know, pulls the rug out from underneath people. And if we can set a date, I think it gives people hope that we're going to get back to some sort of normal operations. And I don't want to take that away from folks. So we're going to aim for that pretty tight. Grace, back to you.
Yep, we got one from Marissa, who's on right now. This was actually one from Yammer too. Hi, Marissa. All right, so Marissa is asking from a coworker who could not make it on time. I would like to see some transparency in relation to the percentage of field employees that have agreed to and are currently providing voluntary overtime. Those of us who volunteered immediately agreed to what was originally a 2-month commitment, which has now potentially turned into a 6-month commitment. Is there a plan for mandatory overtime so that we can all step up and more evenly distribute the workload?
Yeah, so I'll take this one too. I think we had this later in the Yammer questions, Grace. So a couple of questions in there. So I think transparency in how many folks have agreed to voluntary overtime is important. I don't have that number. It's a number that we're working with the scheduling department to try to get so that we can share X number of employees have volunteered. I think that is important for folks to know. And we will effort getting you that number. I don't have any issue sharing it. I just have to get my hands on it. The second part of the question, so for those who have volunteered and agreed to a commitment through January, and now they feel like this is a 6-month commitment, I would refer you back to the email we put out, Michael put out. And what we asked directly was if you volunteered for a permanent voluntary overtime spot, that knowing that we're going to move to April for the shift change, if you can continue to volunteer, we will appreciate your effort. If you cannot, we need you to raise your hand and let us know. In fact, you're asked to talk to scheduling, and we would remove you. Now that will have, downstream impacts about when and how we would have to move to mandatory overtime. But there was not a direct request for those who volunteered to now you must. There is an ask that if you can, we would appreciate it. And if you cannot, raise your hand, let your supervisor know, talk to scheduling, and that's understandable. We're trying not to force you into that decision. And then the mandatory overtime question is another one that was, I think, in the Yammer questions as well. And so to be very clear about mandatory overtime, it is a step in our progression. It's going to be triggered on a couple of things. Basically, our ability to produce unit hours reliably, which again relates to how many employees are in isolation quarantine at one time. If we have a good uptake again in vaccination and that reduces the isolation quarantine, that's great. What's our call volume look like? What's turnaround times at hospitals look like? And if we start to struggle meeting our response time criteria as workload gets excessively high, we will pull the trigger on mandatory overtime. Later this week, you'll receive a communication about what that process looks like. You will not hear me clearly, you will not be receiving a communication that tells you we are moving to mandatory overtime today or this week. You'll receive a communication about how we're going to do that. Many of you took an opportunity to fill out a survey and tell us if we had to move to mandatory overtime, where would you like to be placed? You will see your placement. You will see where you have been slotted in for your mandatory overtime, and we'll talk about how we're going to turn that on. Right now, we're relatively stable and maintaining stability. I don't anticipate turning mandatory overtime on this week or next week. Our situation changes very quickly. We got a holiday coming up, and that's a hard time for folks because we all want to gather with friends and family and be together. And we know that Thanksgiving caused some increase in isolation and quarantine locally within our organization, and then a higher burden of disease in the community. What happens after the holiday week we have coming up or during that week, I don't know. So we have to stay in a state of being prepared, and being prepared to have to move to mandatory overtime is something we could do if needed.
Very cool. I see Brian, you're next, and also after that we have Lee and Tyler. That's the order we're going in. So Brian, do you have your hand up?
Yes, I did. Assuming you can hear me. First, thank you for coming out and actually explaining this to us and being available. I do greatly appreciate that. Secondly, the first question I had is back in the summer, I was asked to move my shift 3 hours earlier. My normal shift started at 6:30. I was moved to 3:30 to help with availability. It wasn't a problem then because my children were on full remote learning. They're staying on it for now. If they decided in March to go back to school, if the school decided to bring them back in, I have nobody to pick up my children. And it's the reason why I picked for a shift that starts at 6 o'clock or later all the time. I wanted to know, is there anything, or is there any way there could be some sort of account for the people who had a different shift and was asked to switch it already this year? And it wasn't an issue then, but now it may become one, if you understand what I'm saying. The second part of my question is, with the mandatory overtime, the one thing that keeps me from not mandatory, I'm sorry, with the permanent voluntary overtime, the one thing that keeps me from scheduling that is that it's a permanent thing, and I have, again, kids and elderly parents I have to make doctor's appointments for and such. Is there a way it could be set up, or is it possible to do it on a month-to-month basis where maybe 1 month I can, the next month I can't, etc.? Thank you again.
So Brian, for your first question, thank you for changing your shift earlier this year. We really do appreciate that. And what I want to make clear in our communications today, and as we have been trying to with the stuff we've put out, we understand that these situations can cause individual difficulties. And we really need you to speak those difficulties directly to your supervisor. And if you don't have success in being heard from your supervisor, raise that with your manager, either Michael or Jamie. We do have the ability to process hardship type requests and manage them on an individual basis. So please take your issue specifically and reach out to your supervisor. We've heard you today. I know Mike and Jamie are probably taking notes, but raise those issues and make sure you're heard. And when we can, and when we can help you and serve the system at the same time, we will effort to do those things. We don't have capacity 100% across the board for everybody. We've got to balance the needs of the system with the needs of the individuals, but our supervisors are a great pathway into doing that. And then your second question about permanent voluntary overtime and the need to do it on a more month-to-month basis. Again, I would ask you to reach out to your supervisor and give them what your proposed solution is. So if you, and what we're asking for permanent voluntary overtime is an extra shift every pay period. And so if you can look ahead every pay period, and you can look into January, February, or March, and you know generally where your appointments lie and generally what your childcare needs are, and you can talk to your supervisor and identify, these are dates that I can work, these are dates that I can work, and these are dates that I can work. We can work with you to schedule that directly. So have that conversation with your supervisor, a calendar, and your availability to work. And we're more than happy to help you schedule that permanent voluntary overtime so that you're counted in that group. Thanks for your questions, Brian.
Thanks, Brian. We got one from Lee. Assuming we switch in April, will we then only be on the new schedule for 8 months, or will the bid next year be due to start in April, giving us the full 12 months on our schedule?
Yeah, that's a good question, Lee. And something that, frankly, between now and April, I'm open to feedback on. I don't have a hard decision on that. I see pros and cons both ways. We've always done it in January, which doesn't mean we always must do it. We can look for other reasons and other reasons why. There is some pro to doing it at the start of an academic calendar. So January is typically when folks are in college or community college or their kids are in school. We have a sense of schedule for that semester. So it's nice to change on that semester break, but that's just one input, one piece of feedback from folks. And so what I would say that I'll take away from this conversation is we need to identify a way to get feedback from folks in the field about how we should look forward to the next shift bid. And is there a preference and can we come to some consensus among the staff about when we should make that next transition? I'm pretty open to hearing ideas about that, and we'll create a forum specifically to hear those inputs. I think it's a good idea.
Perfect. Let's see, Tyler, you're next. How many field employees volunteered for shift extensions or extra days, which I think you already said. We'll have to get that number. correct me if I'm wrong. Also, will their contribution be taken into account during their annual reviews? That was also a Yammer question.
Yeah, and I think Chris Simmons, who's on the call, put a good answer to that question in chat, that the supervisors have that opportunity to reflect in performance reviews, specifically in competency scores, individuals' performance and achievement outside their metrics. I think supervisors should do that. We can provide guidance for how that can happen. It will be made easier when we have a list of names of those that have. Clearly, those of you who have volunteered for a permanent overtime shift during this period have stepped up, have demonstrated your commitment to the organization, to your peers, to your patients, and those are all things that we should recognize. And one of the ways we can recognize that is by making sure your supervisor is aware and can have that reflected in a performance evaluation.
All right, we have a couple of comments, and I think they're both some ideas about doing the shift bid in different ways, so we can record those for you. But is there a chance for a new bid in April based on the new demands we would find? That's from Marissa. And then Lee, a few of us have tossed around the idea of doing the bid in July. It would align with the fiscal year, and college and school years would also align better. So maybe stay on the next shift for 14 months and start in July. So those are just ideas that I'll definitely write down if you're good with that, John, and we can consider those.
No, I think we should record those ideas and involve folks in the moving forward piece.
Okay. One, we got an email question in. Lester just posted in the chat. So after a discussion with a supervisor about this change took place, I asked if they were aware of the change beforehand. I was advised they were told the week before and told not to discuss this with field crews. Now they were told not to discuss it because it was not finalized yet, nothing changed. Why withhold this information from the people it was going to affect? Telling them and advising not to have conversations about it, in my mind, is lying and covering it up.
Yeah, so let me be clear about our relationships with our supervisors. So we communicate many things with supervisors well in advance of communicating to the entire field. It's my responsibility that we have clear messaging throughout the chain of command. So when decisions are made either at the director team level, at the operations management team level, or our operations leadership team, the folks on those teams deserve an opportunity to process those decisions, ask questions about those decisions, make sure they have clear talking points. So when they come and talk to you all, they have answers to questions and are not, surprised. Now, do we do this well all the time? No, it's always a challenge. Sometimes we rush messaging and supervisors find out in a very short period of time. Sometimes we delay messaging so that people can sit with it and we can think about the most appropriate language to use to communicate it to the entire team. And that was the case with this last communication. We knew it was going to be a difficult decision to share with the organization. And so to be clear, the decision was never going to change. It was the wording and the phrasing around the decision, the importance of understanding that the talking points that we wanted supervisors to own and share, that we needed to make sure that they were clear on. And it's not appropriate, it never has been, for folks to get ahead of messaging. And so when we give a message to supervisors, it's my expectation that they hold that message until all are informed, and then have a conversation with all of their employees, as opposed to having messaging trickle out because I told my friend and my friend tells my friend, and then I'm starting to play the game of telephone, and sometimes the message gets manipulated or changed along the way as we're playing that game of telephone. And so this is a common practice where we make decisions, come up with messaging, share it with our supervisors so that they are clear about what that message is, and then we pass it down to the field. So This is not something new. And frankly, it's strategy and corporate communication to make sure we have clear messaging and we have one voice on our decisions, which is very important. Sometimes we do it well, sometimes we don't. Sometimes we put out a message that people don't like, and that's, you know, the job that we have to do. So that's what I got on that one. Grace?
All right, perfect. We got one from Marissa. If there's always a learning curve for the new schedule and we come across this problem every year, is there any thought to changing the way we do shift bid entirely to help reduce these problems? For example, if certain shifts and employees are happy where they are, maybe negating the shift bid and allowing partners to stay together on their current shifts if they do desire without stress of bidding. So I don't know, if, John, if you want to take it, or we got Jamie and Michael on too.
I've done a lot of talking. Michael, you want to take a crack at this one?
Yeah, good afternoon, everybody, from my 9th day of quarantine, if you're wondering why I'm sitting at home. You know, I think anything can be put on the table as far as going forward, the work we do forward on what does shift bid look like, you know, how do we, you know, do we stay on for 14 months? So whatever that looks like, I think it's all good questions that we'll capture and we'll put in part of that work. I think from a learning curve standpoint, I think of it kind of like, you know, I've been trying to think of how I could relate this to like an incident. So I think about being at a wildfire and being on the fire line, and you start having your tactics meeting about how am I containing, when you think of demand like a wildfire, how am I containing the fire? How am I meeting the demand of putting that fire out? And so we always have the planning P that we circle through. We look at the tactics of that. And so when I think about implementing a new schedule and how we do that work to identify where we might have hot spots and that we need to refocus efforts, I think of that kind of like a wildfire in the planning P of how we work through that from an incident. So I think that's the reason why we have to continuously kind of do change to a new schedule when we implement it.
Thank you. We got one more from Tyler. Are there other alternatives being considered to improve UHU other than mandatory overtime? The Omega program is excellent, but its results have only helped marginally. Can BLS response, hold on, I got another one, be considered? We hire EMTs at a much faster rate than paramedics, allowing us to upgrade current EMT non-crew chiefs to the crew chief role much faster than we would paramedics. BLS calls, I believe, are the majority of our calls. Jamie, I'm going to give that one to you. That also came from Yammer as well.
Yes, so we did try BLS 911 a while back, and I think Vashti answered this very well since she was part of that program. So with the MPDS, the different determinants when the caller calls 911, there are whether or not it's ALS or BLS based on what the priority is. So in part of those issues, we've committed to the county, if it's ALS, we will send a paramedic level ambulance. But whenever we did turn on some of those to be more BLS, there was some billing issues because we bill based on dispatch level of service. So in trying to work through those, we still stumbled across that the BLS units, even though they were trained, they were still calling for 911 trucks for ALS evaluations or ALS transport, and we were sending twice as many resources. So not that the project completely failed, but it was not as successful and helpful as it is in other systems. So our BLS trucks do currently help out in the 911 system, especially when it gets to low system status, and they do a lot of those Omega transport only. We have a hard time recruiting some EMTs to be BLS team leaders currently, and even though they get the raise and the shifts that are different, there's still not a lot of want, and we have not turned it on as a mandatory thing, but that is something that we have discussed in the past. Don't know where that will be for EMTs later on down the line, we are open to looking at a lot of suggestions, so we'll see where that goes.
So one thing I'd like to add, Grace, is Chris Hackett's got an email in there, or a question in there, that his end question is a feeling of resistance to change in this manner. And so, you know, I want to really hit that kind of head on. So we, through many different types of projects here at Medic, have tried to best align our response configuration with the needs of patients. Now, being in an all ALS system with the first responder setup that we have, sets a different set of constraints upon us than other organizations may have that are pure fire-based or contracted services providers that aren't third service providers like we are. And so it's not that there's resistance to change, it's that we have to understand how to change in the healthcare setting that we are in. And so we have different barriers that we have to overcome. And I think that we're very interested always in making sure we're trying to find the best alignment of resources to people. And we're going to continue to strive to do that. And the way we do that is very methodical here. We're very data driven from that perspective. And those snap changes we probably won't see in the midst of a pandemic because they need to be somewhat sustainable. So it's not that there's resistance, it's that the system we have in place has to be managed and we have to meter that change over time. And I understand to you all in the ambulance every day, taking care of each BLS patient or each transfer, it feels like change never happens or that we're resistant to it, and we're not. But we are a little slow, and it's with intention.
Yeah, I'm going to go ahead and, Brian, I'm not going to skip over you. I'm just going to go to Lee really quick, his question, because it relates to this. What about just putting a few more BLS trucks on the road as a form of backup, not changing the responses, but having crews available that are more available to hire? So I think, Jamie, that might be yours.
Yes, again, it comes back to the team leaders who are willing and the resources to be able to put them out there. We would love to, but again, we can't have them sitting around doing anything because that's wasted resources. And if we have a relief crew chief, we're better off putting those EMTs with an ALS truck where they can handle all of the calls.
All right, and Brian, I'm going to go ahead and bring your second question up too. Could we switch the ALS net to 911 and add a couple of BLS crews for the BLS net and Omega? Jamie.
Yes, we could, and we would love to. Every year at the shift bid, when we ask EMTs who would like to upgrade to relief team leader or team leader, there's not any that raise their hand. They want to do the glorious 911 ALS trucks. So until we make it mandatory, which is something that we would have to look at in our system, we can't just put them out there without the training.
And I'm going to go back to one I missed. How are we planning beyond April should this pandemic continue, and can we be a part of that process? John, maybe?
Yeah, so we are planning short and long term in our response to the pandemic. And we have, best laid plans to get us to April. And I'm hoping that we will see those plans to fruition and we'll be in a more stable place. Long term, there's going to be a massive vaccination effort within our community. EMTs and paramedics are by protocol allowed to provide vaccinations. EMTs under emergency authorization by the state medical director here in North Carolina, which is great. So there could be a role for us in that part of the pandemic response, especially if we stabilize our business before April and we're producing reliable unit hours, and then we have folks that we can spare. I think that would be a great way for us to engage in the community and provide support to our public health department and to our community.
All right, Jamie, you commented one from Noah. Would we look at going back to, is it minimum bids to realign as needed? Who wants that one? Sanford? Michael?
I think, yeah, I was gonna say I can jump in and talk about the old process, and could we go back and look at how we used to do shift bidding 10 years ago? Yeah, certainly as part of the work, we can put that on the table as something to be reviewed, and that was a little bit different than we've currently do our bid process every year.
All right, got one from Marissa. Would there be a benefit to making that mandatory, the BLS team lead? As there is currently a mandatory upgrade for paramedics, it seems fair for the same of EMTs, considering the high number of net calls run by 911 trucks. It may help reduce that demand and strain, which could then be used for Alpha and Omega. So Jamie, I'm gonna hand that one to you.
Yes, we have discussed that, even within this last year before the pandemic. Again, brand new EMTs get hired here. Whenever they get their shift assignments, if they get assigned to a BLS truck, this is not what they signed up for. They don't want to do this. They want to leave. They don't see any opportunities of learning their way around. They don't see all the benefits, whether it be 911 or net. They want to be on the ALS trucks. So yes, there is some potential in making the policy change and making it mandatory for EMTs. That's a lot of work in a work group, which during COVID, we've been getting a lot of work done quicker than normal. So we'll take all of these suggestions back and see what we can get done with them.
Hey, Grace, Lester just gave me the 15-minute warning. So maybe I think we've talked around this issue a bunch here. We're not going to get to a decision today where we're going to do one thing or the other. I think we've put a lot of effort into talking about where we are and why. Maybe we can see what other topics we have out there before we hit our 4 o'clock window.
Yep, I will record all the BLS comments and make sure we follow up on that for sure. So I'll go back to the Yammer for the shift delay stuff. We have a couple of people, same topic, I think. It's messing up their schedule from paramedic school. Also, like they had a vacation plan on their days off when they thought they were going to have their days off. So I guess, Michael, if you can answer that question, what we're going to do about those problems.
Remember where my mute button is. Yeah, so again, certain hardships, if you have those, make sure you reach to your operations supervisor. They will bring that up to Jamie and I, and we are reviewing those hardships to see what, if anything, we can do to assist in those cases.
Jamie, I have one for you. How is this going to play into new crew chiefs?
So the current relief crew chiefs that are finishing up all of their ride time now will be placed on a shift/schedule opening as needed with and when there's an EMT partner to be with them, just like we do in the middle of the year currently when we do upgrades.
All right, I have a long list of ideas people have submitted on Yammer to help kind of stabilize the system. So all of these are recorded. Leadership has them to consider, but I'll just pick a couple to go through for some of our time. I don't see any more questions yet. I've had a few about CMPD and the transport process to behavioral health. Seems a lot of people said they're not compliant. So Daniel, I think you're on. Can you give us as supervisors insight on that process and how it works, and if you've seen that a lot?
Yeah, so the biggest thing with this is any different that you have with any situation on a call is getting it done in the moment of. So anytime you're running into an issue with CMPD and you're having a psychiatric patient, the biggest thing is to get them the resources that they need. So if you're having a patient that is appropriate for mental health and you're having any kind of issue with CMPD and a possible transport, that's something that you need to get in touch with the supervisor on at that time so that we can look into it. The other thing to remember is we get notified of Billingsley's diversions pretty update. We get a timetable of up to 12 hours that they could be on diversion. CMPD, each officer isn't necessarily got that information. So at the beginning of the day, when they get told that, Billingsley is on diversion, they might not get that update throughout the day that they've been off of it. So just keep that in mind. It's not always necessarily that they just don't want to do it. It's just that the information that they have. So just at the time that it's happening, if you have any issues, just get in touch with a non-duty supervisor to kind of help you guide through that situation.
And I'll give this one to you too again, Daniel. The closest hospitals, why don't we do that right now, especially during COVID?
So anytime that we've ever done the closest hospital in the past, it's typically been for some kind of weather event, whether it's snow or ice. I know we recently did it for a couple hours a few weeks ago due to system status level. That's something that's for a brief period of time so we can get basically through the big rush. If we're doing it long term over a multiple month period, and if I'm mistaken, please correct me, but that's something that not only are we going to have to let our community know, so basically having to set up kind of a news outlets, basically letting everybody in our county know that this is how Medic is going to handle transports from here for the foreseeable future. But that's also something that we're going to have to get approved by the medical board. Both hospital systems are going to have to be a part of that. And the thing you got to remember is you have hospitals that are like Mercy with small bed counts in the ED, and they are the closest hospital for a large part of our population that we're going to overrun them. And then there's also things about the hospitals wanting only COVID patients transported to their certain facilities. So that's a big decision that you have to get approval from multiple areas. And it's, from what I know, it's wouldn't be something that they would consider for a long period of time.
Thanks, Daniel. Patricia, if you're on, I think you are. We had an idea about increasing kind of options for high frequency plans for the repeat users. If you can speak to that and any opportunities you see happening, maybe?
Yeah, definitely. I will say this program has still very much so been alive in COVID, which is great to see, even though our caseworkers are really busy with all the COVID work they have going on in their hospitals. The good news is overall, our high frequency users as a system has actually decreased significantly in this time. So we're all still feeling the same 1 or 2 people who call a lot, but overall we have a lot less repeat customers. In terms of the people we are working with, definitely still reach out to me and Allison about specific people. We're trying really hard to push these interventions. Both our system needs it and these patients need it right now. So we're doing what we can with our team, trying to do what's best for these patients. It's certainly not enough to fix system status, but it's the right thing to be doing.
Thanks, Patricia. Trying to pull out the most popular ones on Yammer or that I've gotten through email. We've had a few about why don't we stop pairing crew chiefs and make 2 trucks out of those? Either Jamie or Michael.
Yeah, I can take that. So we're doing a lot of work on the schedule right now, and our goal is to produce unit hours, and so we're doing everything we can to get units out the door reliably and to beef up the system to drive down workload and to meet the demand that's kind of erratic. So when we have the opportunities and the need to split folks up, we're doing that. But a lot of times it's basically the need's not there.
Thanks. And Jamie, I have one for you. What about NET? Can Atrium and Novant take on more of the NET side?
Currently, Atrium and Novant are having worse staffing problems than we are. They are trying to reserve their critical care transport units for critical care transports. And even so, we are getting more of the Novant sick people that would have been their critical care transport level than we have before. And we're seeing more and more of those, and their critical care assets are having to transport for longer distances, which we prefer not to do. We prefer to stay in county. They are doing the long distance transports to Rowan County, to Union County, to Lincoln County. Right now, we're all, I don't want to say struggling, but all using what we have when we have it, and they don't have the resources.
Tyler, that's just you. Everybody can hear. See, I got room for like at least one or two more. What about 911 calls to EDs? Can they be listed all as alpha, Michael?
So when you dial 911, any caller dials 911, we have to go through our medical priority dispatch. For that call, we cannot deviate from that and change that to an alpha response because somebody informs us they are calling us from outside an emergency department. If they do call from inside an emergency department, we have a protocol in place, a process that we follow to contact the facility as well as dispatch an operations supervisor to investigate. So that's kind of where we're at with that in that process, if you will.
Thanks. Now I'll go to the comments. Instead of closest hospital or of choice, how about need? Meaning STEMI and trauma are obvious, but expand that, such as a pregnant patient delivering at Maine, chronic medical care at Huntersville, et cetera. But the people who utilize us as a cab without reason would be closest. Michael, I'll give that one to you too.
Sorry, my mute button wasn't working. So again, there's a lot of work that would go into the changing destinations piece. That's not just medic; it also involves both hospital systems and their capacity. So we can capture that information. I don't have an answer today on how we could make that work.
Yeah, and I'll just tag on to that. The hospital destination and destination determination is not a decision that Medic gets to make as a single entity. Destination protocols and destination determination is something that is decided by the Medical Control Board and the hospital executives that are part of the governance structure at Medic. And the other thing I would put in there, oftentimes tongue in cheek, I will tell people that the most complicated protocol that we have in our protocol book is our destination protocol, because our destination protocol is like 4 pages long. And there are consequences when we take people to the wrong place. So things that we do that make the destination protocol more complicated may sound good on paper, but may not be something that we would appreciate operating, either as individuals making those decisions or those of us operating managing the situation. So those things are a little bit more difficult to change over time.
And this is a good question to close it out. So there's a lot of good long-term solutions we just talked through. But Chris Hackett had a question: what is currently being done other than mandatory overtime in the short term to help UHU and reduce crew fatigue? So I'm thinking John, Michael, and Jamie could probably answer that. John, you want to take it?
Yeah, so I think that there's a whole set of pieces that we've looked at that have varying levels of impact onto the situation, from being very intentional with our day-to-day pairing and making sure we have hours built when we need them, to making sure that our dual role providers, our administrative staff who have certifications, are meeting their requirements for permanent voluntary overtime in the field, to implementing Omega, which could happen next week at a broader implementation. We're sending some psychiatric calls to Cardinal Health and not responding to them. We have a really innovative project where we're looking at using Lyft to transport Omega transport onlys. That's not off the ground, but there's a whole bunch of stuff we're stretching for to reduce volume and make sure that we're responding only to those patients who need us. And then at the end of the day, we must produce the unit hours needed to reach our patients on time so that we can deliver the care that is needed. And if we can avoid moving to mandatory overtime, we will do so. And if we cannot, we will move. We'll be clear about why we're moving, when and how. We'll operate in that period, and then we'll move back when things subside. And we have to live in a period of uncertainty as to when that may or may not occur.
I will also add that the hospital systems are also trying to utilize the patients going on their own or a ride share service for some of the lower acuity, like from the freestandings that we see going to Pineville and other places. This is something that I've been in a few meetings with them trying to get accomplished and help educating them as much as possible on which patients don't meet the description of medical necessity. So those are ongoing talks of the hospital systems trying to figure out their own volume.
All right, with that, John, I'm going to throw it to you to kind of close, just for my part. Again, we're capturing all this stuff. I see a big theme with the BLS kind of work, and then CMPD and that process. So I have that on my list to kind of communicate that more with leadership and with employees. Other than that, John, you can kind of close, and Michael and Jamie and Daniel, any comments you guys want to make?
Yeah, so I'll close it out. So one, thanks everybody for taking time out of your day to participate in this forum. Pretty decent attendance. We'll take the recording and we'll put it up so that others can see it. And we'll try it again and see if we have the same level of engagement on different types of questions. And really, in closing, if we go back to what kind of spurred all this, we're still in the midst of our pandemic response, and this has been a rough year for everybody, from frontline through the organization. We've all been faced with different challenges, and we've all risen and met those challenges and continue to do what it is we are here to do, which is to serve our community and take care of our patients and take care of each other. We're going to continue that focus on our mission over the coming months. We're going to do our best to put our patients first, to take care of our employees, and to manage this organization in a way that when we come out the other side, we'll be in a stronger position as an organization. And it takes all of us to do that work. And it takes all of us focused and committed on the reason why we got into this business in the first place, which is taking care of patients, to be able to do that. So thanks for participating. Thanks for maintaining your focus on your patients and taking care of each other. You know, we're closer to the end than we are to the beginning. You know, there's a vaccine on the horizon. It's going to take a long time to get it all the way through the population, but there's a little bit of hope there. So hold on to that. And if you haven't already, make sure you fill out our survey online about vaccine prioritization. I want to be able to send as many people to public health on Thursday that are interested in getting a vaccine as possible, and get them our initial list and get those vaccines started. So make sure you do that. That's the start of our hope, and hopefully the end of where we are. So thanks everybody. Have a great day. Thanks Grace for setting this up, and Lester for looking in the chat. Mike and Jamie for your answers to your questions. Daniel and Patricia for piping in on your subject matter. So everybody have a great day, and we'll talk to you soon. Thanks.
Thanks, everybody.
Bye, everybody. Corey, ask your question.